Well, thanks everyone. Good afternoon. And I'm Stephen Wang. I'm the data science lead for the primary care stratified medicine research group at the University of Nottingham. I'd like to start by giving a bit of a presentation about a condition we probably all are well aware of, familial hypercholesterolaemia. And instead of going into the research aspects of where we've come from, I'm going to give you a bit of a linear presentation about the journey we've taken to get what Imran had one of his bullet points was about developing a patient pathway for familial hypercholesterolemia, which I'll refer to FH from here on out. And we all know that it's underdiagnosed. There's a significant burden to the individual and families, but there's effective treatment. And if we can identify these individuals better through systematic case finding in primary care, we can treat their family members, and we can reduce their own individual burden of heart disease. The first thing we did was to kind of understand in primary care the etiology of the condition. So we did some database modeling initially, and this was using patient records from the Clinical Practice Research Data Link. And we've extracted from that data set 2.9 million patient records, including 5,000 confirmed FH cases. And the more we looked into phenotypic factors prior to diagnosis, we started to build a picture of that actually there was a workup to these individuals, because as some general practitioners in here will know, that oftentimes you're treating the phenotypic symptoms and the markers of elevated cholesterol, you're recording family histories as they present opportunistically, and we can start to build a picture of what an FH case is before they actually are officially diagnosed. So we tested this model in an independent sample from the same database, and we found that our AUC statistic in our tool called the Familial Hypercholesterolemia Case Ascertainment Tool was around 0.86. And that was better than when we applied the Dutch Lipid Clinic and the Simon-Broom criteria to the same primary care data sets. And that's led to, you can have a look at this paper. So that describes the process and the approach. Those are the diagnostic variables indicating a pretest probability of FH. And you can see in there, you have your lipid markers. We included triglycerides because that was a negative indicator with elevated triglycerides. Age was a negative indicator as well, in the sense that if you have a patient that was a younger age with elevated cholesterol, there should be a higher pretest probability for FH. And negative indicators including secondary causes like liver disease, diabetes, hyperthyroidism, and chronic kidney disease. At the same time, we decided, well, we need to make a funding application to test our tool. And so we made a funding application to the NIHR. And this study essentially was a mixed method study. The core component was an observational study, but we were also doing some qualitative and economic evaluation on the entire approach of systematic case finding. Importantly, we convinced our funders that the resources for 365 patients for NGS to be done within primary care. And that's really interesting because that, in a way, this is a feasibility study of testing a genetic panel of FH markers in a primary care setting. At the same time, the algorithm was a piece of paper. So, we couldn't test a piece of paper. We had to go and do some intervention development. And funders are pretty bad at funding for intervention development. We don't, there's limited opportunities from the step of, getting something that's a research piece of work into an actual practical application. So with our informatics partner, Primus, we secured an independent research grant from Amgen, and Primus embedded the algorithm within the software called Chart, and that's essentially you might have come across Grasp AF, similar type of concept. It's an audit type toolkit. Just pointing out that this is the summary sheet of the tool, and we have diagnosis and screening metrics, some family history recording, and of course some drug prescribing. But what's far more interesting is the back end, is the ranking feature. And because FAMCAT takes routinely available data within the primary care record for patients. We use that and actually generate pretest probabilities for FH. And I blew that up a bit, and you can see that these patients are ranked highest to lowest. So this is from a test practice. This is anonymized. And everyone that I've highlighted are people under 50 with raised blood lipids that haven't been assessed for FH. And of course, if you are all interested in using it in your practice, it's actually freely available on the Primus Hub. So this gives a web link to it, and you can certainly take a look and set it up in your practices if you're EMIS or System 1. So at the same time, the question comes up, what's workload? You know, what is the GP workload for assessment? And that's the question we needed to put before we started to run the study to be able to give an answer to. So we did some intervention pilots in a few different practices. And you know, initially, we put a pretty liberal population prevalence threshold of 1 in 500. And that amounted to about 2.3%. Now, that's quite a lot initially. But I think I would like to stress that the ranking system in the tool will prioritize patients with the highest probability. So we tell GPs, you know, how much resources do you actually have in terms of your local area for genetic testing, also in terms of referrals that you're allowed to have. And you would start screening the list from the highest threshold to the lowest. And instead of asking, you know, where to screen at, we advise on, you know, what are your resources look like, and then start targeting the highest probability individuals. So that looked pretty good. You know, all the technology was working at the time. So we got together in our study team and started to get the study approvals in place. And this was liaising with the CRN and a lot of the local clinical networks. So these are all things that anyone running a clinical study would be familiar with, getting questionnaires, practice posters for opt-out, and because we're doing screens of the electronic medical record, our patient invitation, consent forms, and of course, information sheet. And all in all, this took a 5 to 6 month process. So building this time in is quite crucial into your time frames. So there's 3 kind of key approvals. There's sponsorship through your local area, or if at an academic institution, it'd be the University of Nottingham. In our case, we went and got local R&D approvals from HRA. And then the third point is really quite crucial, actually. If you're going to do things, informatics-based interventions in primary care practice, you need local area governance, IG governance approval. And that varies area to area. The area that we encountered, we started the approval process about December and got approvals 6 months later. So it takes some time bouncing back and forth. At the same time, we needed to drum up support, and we were engaging with our CRNs to obtain EOIs. We were doing academic detailing, going to GPSI events. Like an event like this is essentially a good forum to engage clinicians to join up on the studies. We're offering CME sessions and other protected learning. And of course, crucial to this, we need secondary care to be on board. We were going to increase referrals for gene testing after we've identified individuals. So Lipid Clinic has to be happy with the numbers coming in. Okay. So we know that the practice has expressed an interest. We've got into the practice. We've established clinic days. And crucial to that is it needed to be in the beginning of the week because the DNA samples had to be delivered to NHS labs within 96 hours before DNA denatures. And after we started recruiting our studies, the crucial bit, which is almost a given, is communication, iterative communication between the study team and the practice team to support any of their needs. And each practice is different, so we're trying to be as flexible as possible. Where are we now? So we have all our approvals. We have 8 of 15 practices recruited. 6 of 8 baseline extractions of FAMCAT done. We have 156 of 365 patients recruited. And I won't give too much away, but we've had 100% genetic test attendance, which is quite impressive. And the absolute number is 44. What will we learn in terms of detection rate? Well, we have a gold standard positive diagnosis of FH using FAMCAT. So we're going to get some good information, and hopefully these patients will be later on treated, and then we can identify more family members through cascade testing. We'll learn about the acceptability of the testing and the thresholds for cost effectiveness at various thresholds. And this bit is really interesting because of our rich data set. We'll be able to do some secondary data analysis of the genetic data with full clinical histories. And that's really the development of the exemplar stratified medicine in primary care practice. And I'll just end on this slide. And this is the kind of information that we're actually going to obtain from our study in about 12, 18 months' time. So we'll have mutation negative, which make up the majority. Then we have some polygenic, stratifications. And then we have our monogenic diagnosis, and then variants of unknown significance. So we'll explore the interaction between these stratums and clinical histories and the workup longitudinally through secondary data analysis. And hopefully, this will will shift away the strategy of one size fits all to a more stratified approach, which is why we are all here today. And this is our study team, so I'd like to thank all of them for their input.